My name is Ashwin Rangan. I have a few prepared comments, but before I make those, I want to just go over a few things. If you look around you, you'll see that this is not a big conference, and there's a reason for that. When we started talking, AJ and I, the question was whether we go for quality or quantity, and my view is at this level, we want quality and not quantity. Not too long ago, I was at another CIO conference where there were well over 175 people in the room. The best you can do in that kind of a conference is hit and run. And after you get hit or after you run, you don't feel good. So that's clearly not a good outcome from these kind of meetings. So I'd much rather have quality time with a few people than quantity time with a heck of a lot of people, none of whom I feel like I've met long enough. The other thing is this is a concentration. If you look around you, people here are either from the med device sector or from the healthcare provider sector. And that's an important consideration because that's the focus. There aren't too many others in the room except for AJ and a couple of his folk. This gives us an opportunity to talk about topics that are topically relevant to us, interesting to us, issues that we understand, issues that we grapple with every day. And in fact, that'll be quite a bit of the discussion breakouts as the day progresses. I was recently reminded by a good friend of mine that there is a primary role that CIOs play. He said, you know, at the end of the day, every C-level officer in the company has one and only one goal, and that is, or certainly should be, to find and keep customers who pay for the service or the goods that you produce and convey to the market. I think that's a very important consideration that we ought to bear in mind, particularly as we go through the Obamacare arc that is ahead of us, only partially, if at all, behind us. How do we continue to leverage what we're required to do under the umbrella of the new regulations that are kicking into place? It was mentioned that this is the second time that we're getting together. Indeed, about 6 months back we got together. The group at the time was about 18 people in the room. AJ and I were talking that if we're able to get to 30 or 40 people, that in itself will be a very good goal for us to have. We have logistical issues. We've confronted those with bringing people together today. We've had, I think, 14 people say they can't make it because this is strategic planning time or it's board time. So we've learned a big lesson and we will be making adjustments in that regard. The next meeting, AJ and his team have already been looking at calendars. Given the kind of lead times that people requested of us, we're thinking that it ought to be on the 27th of March. Am I right, AJ? Yeah. 27th of March. So if you could all make a note of that, we're going to start publicizing that date as quickly as possible and locking in a place as well. That way there's sufficient lead time to plan around it. If I think about what we're planning to do in course of the day today, going beyond just the agenda items, it's really to figure out if there are specific areas where there are opportunities to collaborate. Mike Zell, one of the folks in the room, for those of you who don't know him, comes also like me from other industries. I'm not, unlike what the message there said, it said, I'm an Edwards Lifer Sciences guy. I'm not a lifer in any healthcare company. I come from a variety of other industries, including high-tech and semiconductors, where product life cycles last for about the attention span of a gnat. So coming from those kind of industries, Mike and I were saying that the culture of those industries is high collaboration, but speed to market. In those industries where speed to market is the dominant driver and competitiveness is extreme, your competitors know exactly what you're working on. It's more about how fast can you get your product to market. It's not about do they know what you're working on, which is a very different dynamic as compared with healthcare and life sciences. It's a very different dynamic. Now, as we head towards the principles and foundations of the intention behind Obamacare. The intention is to bend the cost curve, as we've all heard about that. How is the question that remains unanswered. We have an opportunity here. It could be that we could pave the way on how it can possibly be done. If we look at this region in Southern California, it's unique in one particular aspect, and that is we've got a really high concentration of med device and biotech companies. It's unrivaled relative to any other region of the country or the world. And of course, like other regions, we have a concentration of healthcare services providers. If we can bring these two adjacent verticals together, and that's the representation of technology folks here, at the highest level, each one of us is a CIO or a CTO. If we can bring those two adjacencies together, can we create magic? And if so, can that be a transportable model? I think that's the opportunity ahead of us. So this is less about talking heads talking about I did this, I did that, and more about all of us getting together and saying, what can we do? Is there something that we can do? So with that, I want to just take us through a few slides here. Many of these are data points that are widely visible, but I wanted to just ground us with a few facts and figures. I'm sure many of you saw this when it first appeared in the press. A tale of two cities, McAlester and El Paso in Texas, where the overarching healthcare costs on an individual basis were compared by a doctor and published in the New York Times. He showed very clearly that McAlester had a per capita cost of $15,000 per year, as compared with El Paso, which had about $7,600 or so at that time. 800 miles away. When he studied it, he said the reason for almost twice the cost was across the board overuse of medicine. If that were indeed the case and the outcomes were great, it would have been fine. We would have probably said, okay, it's got to cost $15,000. But no, he went on to say that the outcomes were poorer in spite of the overuse of medicines. When the Obama administration came into power, this became required reading. This particular case became required reading in the Obama White House for everybody. It didn't matter whether they were connected or not. What got us there? This is what got us there. This is a comparison of the spending as a percent of GDP across many, many different countries. I'm sure you've seen variations of this in many different forms. But we far outstrip anyone on the face of the earth in our expenditure in overall healthcare as a percent of GDP by a long margin. Okay, so what? Maybe we'll live longer, get better quality of life. What's your point, right? Well, there is a problem. The trend lines are bothersome. And it looks like the trend line is beginning to flatten out from 2009. But that's a trick of statistics. The trick of stats there is that although the percentage has started to flatten, our GDP is increasing. Between 2010 and 2011, we added Sweden. In that 1 year, our GDP added $550 billion. We took 17% of that $550 billion in additional GDP and put that back into healthcare. The population did not go up by 17% in that 1 year. It barely moved. That's why we were looking flat year on year, but in reality, we were pumping even more money. But we could say, okay, at 18%, so what, even that may be acceptable. But no, it's not, because here is the problem. As we spend more, we are not impacting longevity, leave alone quality of life. In fact, quality of life is only just beginning to get measured. I was introduced to a term that is a tongue twister in this by a biostatistician who said that the heteroskedasticity is not positive. I don't know what the hell that means. I said, okay, that's fine. It's not positive. But this tells me that we're not making a meaningful impact. We're spending a heck of a lot and we're not making a meaningful impact. And if you look at the right side of that slide, we have terrific technologies that are really expensive on the front end. But on the back end, from an outcomes perspective, we're 50th in life expectancy tables across 221 nations. We're in the bottom 3 for women's health care overall, bottom 3 in the world. We're in the same league as Mexico and Hungary. And we're in the bottom 5 for men's health. This is really bad. So the stats started to scream out loudly, saying this is not a good situation, it's not sustainable, we should not be standing by. And indeed, when the Obama administration came to power, they looked at this and said, yeah, we spent a lot, the outcomes are questionable, many conditions are applied before anything is extended to anybody, and we don't have universal coverage. Can we do something about it? The result of that is why we're here with Obamacare. And what does Obamacare really bring with it? The Affordable Care Act, many of these things are going to kick into place either the 1st of January or the 1st of April then. 7 different canons that came up. Guaranteed issue, no exclusion from pre-existing conditions. I think we're hearing about this from everywhere. Minimum standards for health insurance policies. We didn't quite understand this when it was first proclaimed. I think in the last 30 days, the nation's beginning to understand what this means, as coverage is being canceled to be replaced with new coverage policies that are more expensive because they're purportedly more comprehensive. We're now beginning to understand, ooh, that's what this really means. No lifetime or annual caps, and children can stay on our insurance until the age of 26. Individual mandate. I for sure didn't understand this when I read that. My son asked me, he's 21, and he asked me, what does that mean? I said, I don't know, I'll figure it out. When I do, I'll let you know. Now I'm beginning to figure it out. He doesn't care until he's 26. But the individual mandate says you either have insurance coverage or the IRS is going to take a deduction. One way or another, the government coffers are going to get filled. Healthcare insurance exchanges in all states. I don't want to talk about it. I think we're hearing a heck of a lot about this. Federal subsidies on a sliding scale up to 400% of poverty line. So depending on your income level, there is a subsidy that can kick in and help you to buy the insurance at a minimum level. Medicaid eligibility up to 133% of national poverty level. That's up from where it used to be. Fee for service to bundled payments. That has an implication. And lastly, the employer mandate. If you employ more than 50 people, and if you don't extend coverage, and they have to go to a public exchange to get insurance, you, the employer, gets to pay a fine. These are the primary provisions in the Affordable Health Care Act. Now, the question that we are here to ask is, affordable as in what? Affordable to the individual, more affordable to us as a nation? What is the cost curve that has to be bent here? And will we be able to bend that cost curve? So I'm hopeful that the discussions today will help us to examine that very theme and see whether we can make a difference. So with that said, I'd like to ask Mike to come up. Mike chaired the last session. I know that he has a few things to share. Bill is going to be standing in for Jeanette. We're trying to bring together both San Diego and Orange County. I come from Orange County. Edwards Life Sciences is based out of Irvine. Mike's from San Diego, and so is Bill. So I come from a med device company called Edwards Life Sciences. Mike's with CareFusion, and Bill's with AMN. So with that, Mike.
Thanks, Ash. I just wanted to share a few words with you because we're not going to be on schedule if I share too many words with you. First, Ash, I think it was a great setup for all of us to try to understand why we're here. I've thrown my support behind ICCG and this effort starting 6 months ago. I learned about this. I think that we have not a crisis, but we have a real opportunity to build an ecosystem. I've worked in the Bay Area. I've worked in semiconductor as well. But mostly what I see is the opportunity to do something different with our colleagues here in Southern California and try to do something exciting. I don't know how we're going to do it. We're going to find out as we go through the days. We're going to give a little bit of an update on what happened in the first time we met a little bit later in the day, so I don't have to do that here. But I did want to add to your comments up here. We have the attention now in the industry is all around Affordable Care Act. I would say that as a company, CareFusion is much more interested not in how it gets paid for, but how it gets delivered, and can we bend the cost curves, so that we can deliver as part of an overall system more affordable care and higher quality. And I think that the industry that we're in is completely ripe for this. It is exactly where semiconductor was in the 70s. It's exactly where, so all the industries that you can name pretty much except government, education, and medicine have gone through a leaning process, in my view, that is going to happen. Exactly how is it going to happen? I don't know. The first step of that is the ACA that we're all going to deal with, both the intended and the unintended consequences of that, legislation and enactment. But I think as an industry, if we're going to be successful, we're going to have to find a way to get down a cost curve and down a leaning of the industry across the board. Doctors, hospitals, nurses, medical device, insurance, on and on, is all going to go through the same thing. That means great opportunity for Southern California if we do it right. And so that's what I wanted to put my weight behind this kind of conversation with you guys, to see if we can find ways to make ourselves more competitive as a locale, or SoCal, as it were. Kind of funny. But I think that's what I'm here for. I don't have a lot to say beyond the setup we already had. We're going to say a little bit more later. I think about the call out of the first group. I was involved with the talent group and how we attract and retain talent. I have a little bit of conversation on that. But I don't want to say a lot now because we're going to have time to say it then. So, Bill, do you want to give a couple words?
Yeah, sure. Actually, I have a little deck here.
Sure.
So, good morning. I'm Bill Cortez, VP of Enterprise Architecture and Solution Delivery at AMN Healthcare. And although I guess the ICCG wanted to give me a promotion to CIO according to the agenda, I'm just standing in for Jeanette. So today I'm just going to spend a little bit of time to tell you a little bit about AMN Healthcare, because it is a little bit different from the med device industry, and our interpretation of some of the trends that we're seeing to fall out of the ACA. And how it may or may not impact our business as we move forward into 2014 and beyond. So let me figure this one out here.
Yeah, right and left.
Right, left, yeah. Coming to it, right. There we go. So who is Amen Healthcare? We are a publicly traded company. We're probably in the neighborhood of $1 billion in revenue. Publicly traded on the New York Stock Exchange. Our stock is roughly about $13 to $14 on any given day. We are the innovator in healthcare workforce solutions and staffing services. And we provide that to our healthcare facilities across the nation. What that really means is that we're sourcing physicians, nurses, and allied professionals across the country and placing them with open job orders from our facilities. One of the things that we do very well is offer managed service programs and recruitment process outsourcing for some of our key clients. Our key clients are really those acute care hospitals, government facilities, and common health centers and clinics, community health centers and clinics across the nation. We are considered one of the largest healthcare staffing companies in the nation. We have quite the candidate pool and network to source just about any kind of physician, any kind of nurse, and whether they're on permanent assignment, travel, or per diem, we have the resources to fund those. So some relevant industry trends to our business, right? I mean, remember, we're not building devices, we're in the people business. So what does that mean for us? I mean, when you start to look at the catalyst for all of this, we're expecting that 32 million Americans, obviously not on January 1st, but at some point will enter the healthcare system as newly insured patients. What that means is that there's going to be quite the uptick in demand. The popularity of high deductible insurance plans are increasing, and so that's also going to change the behaviors of our patients. For example, in 2012, I believe the average deductible was about $3,000 per policy, and that was a 56% increase over 2007. So the idea there is that it's going to change your patterns, right, in terms of how frequently you visit the doctor, whether or not you want to take all of it in year 1 or year 2. Sometimes you want to defer your care to maybe another year to where you're not actually expending your $3,000 or you're pushing it out to the second year. That also is going to change our demand structure. The healthcare providers continue to feel reimbursement rate pressures. The national health spending grew 3.9% annually in 2009, but that was the lowest in 50 years. You know, and that's a lot to what Ash spoke of earlier. Is all of these mandates that are coming in, the propensity to be more effective and be more cost conscious and have better patient outcomes is putting a lot of pressure in terms of financial constraints. The industry is consolidating. We saw nearly 100 hospital acquisitions in 2012, and so that is yet another symptom of what's going on out there. Is the cost pressures that they're seeing are forcing a lot of M&A activity to where they can actually achieve economies of scale by consolidation. All that being said, hospitals continue to be the second largest source of private sector jobs. That's clearly a positive for us. And you know, all that being said, when you start to look at physician and nursing professions, there is a projected shortage 10 years out. And that's primarily due to the demographics of our physicians and nurses today. The average age is anywhere from 45 to 55. And there's not much of a pipeline coming into the education stream. So there is a projection out there that says we're going to have in the neighborhood of 130,000 physician shortages and 260 for nursing. So that's going to put even more pressure, right? Will we be able to do things outside of the traditional physician and nurse? I mean, things like medical practitioners and nursing assistants and other forms of care will be predominant as we start to realize the shortage. Hospitals are now embracing new innovative technologies, such as telehealth, robotics, mobile health applications and devices. I read a stat here. I think it's more than 1.8 million people over the next 4 years will receive some form of telehealth care, and whether it's a phone call to your physician, or it's a video conference, or it's some sort of cardiac monitoring capability. There is a projected need, upswing, that's going to happen in the next 4 years. That's going to create a big explosion in terms of opportunity for savings. You can imagine, instead of staffing an entire facility, you might be able to do this remotely through electronics. That's very powerful. You can actually increase the quality of care through this, so where the patient is not forced to get up out of bed and go to the facility. They can actually be monitored there right where they are, and actually increase the quality of care that they're experiencing. EHR will continue to expand. I mean, we've seen this trend over the last years. It's not going to stop. And so what we see there is that the more information that these facilities know about us, the more propensity there will be for patients to access those records. I mean, today, if you look at Kaiser, they've got a pretty nice portal. I mean, if you sign up with them, you can see everything that's going on with your healthcare record. All your lab tests, your results, you can even communicate with your physician. It's all kind of centrally managed. You're going to start to see more of that. Kaiser's one of probably the more advanced facilities that we have out there, but more and more you start to see the laggers start to follow Kaiser. So what does all this mean for our industry specifically? Well, clearly it's going to change the supply and demand equation. When you think of all of these people that are going to be entering the network, I mean, it's going to create a huge demand for facilities, the healthcare professionals that are going to be treating those patients. The high deductible plans will also kind of disrupt our current supply-demand equation. And given the uncertainty around the hospitals, you know, what they're going to do with their cost-cutting measures, the propensity is to not necessarily go out and hire a whole bunch of permanent physicians and nurses, but to rely more on temporary staffing. And especially during the short term here, where things are kind of ambiguous in terms of where we're actually going to land, the facilities tend to, they're kind of in this analysis paralysis mode, to where they don't necessarily want to commit one way or the other because they're unsure of the eventual outcome. So they are leaning more towards temporary staffing, short-term solutions, and relying on companies like AMN to help them solve those workforce solutions for them. This is very favorable for AMN. Clinicians and physicians will also need to become more technically savvy. I mean, today, depending on what facility you go to, the level of understanding of technology and utilization of technology is pretty disparate. You know, in some cases, you know, the nurses and the section heads still prefer paper over anything else. When you start to think about the daily activity, you know, just submitting a time card, for example, to the temporary physician, they don't want to do that. They don't see that as part of their job, although they're temporary, and they would prefer just to write it down and have it signed and then fax it out. There's more capabilities out there, such as, you know, you could probably do it on your mobile phone, or you could actually do some sort of card swipe thing. You know, the understanding of where telehealth is going and understanding the technology that's involved there is not necessarily a primary catalyst for physicians these days. But nonetheless, when you start to see where the facilities are going in terms of their cost-cutting measures and their opportunities, you can only intuit that they will follow. And so that's going to create a lot of new opportunities for staffing agencies like us. All of a sudden, you'll start to see new skill sets that will be born out of this whole technology capability, in addition to new services that we've never seen before. When you think about the setup of a monitoring situation at home, you know, depending on the level of care that you're looking at, I mean, it could be as simple as a cardiac monitor, or you could even go more invasive. There's all sorts of new capabilities that are evolving almost every other month to facilitate this whole telehealth presence. That in itself is going to drive a new demand for different types of clinicians with new skill sets and more technology-savvy skill sets. So that is also going to kind of shape our structure and how we choose to implement our workforce solutions, and also consult with our facilities in terms of what they should be doing to manage costs, improve the patient outcomes, and then also how to be more effective in terms of managing the cost structure that the patient brings. Because if you recall, there is no more clause where, depending on your previous state, you can't go there anymore. So very positive for AMN. We're doing well, and we're also adjusting with the trends. But whether it's a short-term solution or a longer-term solution, it seems very positive for us in general. So I think that's it.